We are going to talk about cardiovascular disorders and conditions today. Cardiovascular disease remains the leading cause of death in the United States, and it is a global disease that causes more than 19 million deaths per year. The average cost of someone, or actually cardiovascular disease in the United States, was over $407 billion, and that was over a year's time. And the World Health Organization's global action really is targeting those preventable risk factors like smoking, alcohol use, obesity, hypertension, and diabetes to really reduce the burden of morbidity, mortality by 25% as a goal for the 2025 year. And I'm not sure if we're there yet. This is an overview of the topics that we're going to talk about in this lecture. As you can see them listed on the screen here. So we're going to start with really looking at the acute MI population, heart failure, and then some of those structural vessel diseases that we see in the cardiovascular population. So when we look at what is the potential cause for coronary artery disease, essentially it's going to be the same as we talked about with stroke, cardiovascular disease. A lot has to do with some of those modifiable and non-modifiable risk factors, but the big culprit is really associated with the atherosclerosis. And that atherosclerosis is what can deposit that plaque within the vessels, causing narrowing and then really complicating the disease. So when we break down the risk factors, we look at non-modifiable, which is your age, sex, race, genetics, that family history, and really focus on the modifiable risk factors, the things that you can do to improve health, such as diabetes, high lipid levels, hypertension being way up there, smoking, obesity, physical activity, even obstructive sleep apnea. All of these risk factors will increase the risk for cardiovascular disease. And if you have non-modifiable risk factors that elevate that risk along with modifiable, that can actually be quite a problem and increase your risk for developing cardiovascular disease. So we know that as you get older, you will increase that risk of having cardiovascular disease. Men tend to develop symptoms 10 years earlier than women, but the rate goes up tremendously post-menopause in the female population. That family history as well. If you've got someone in your family who's had an MI or a stroke before the age of 60, that can increase your risk as well. Male tend to have more frequency in cardiovascular disease and some of those underlying diagnoses. When we look at different disparities within the race, our African American population has an increased risk and death associated with cardiovascular disease as well. This is both some of the inherent risk factors like hypertension and diabetes that we see, but there's also systemic issues in terms of access of care. You're modifiable with your diabetes. What is the hemoglobin A1C, your fasting glucose? What is the lifestyle, sedentary versus a physically active? Obviously, physically active is going to reduce that burden. You also look at the BMI and obesity being an independent factor that can increase your risk as well. How the fat pattern is distributed, if it's primarily in the abdominal area, that risk goes up for cardiovascular disease than someone that has a smaller waist and larger hips. High fat diet, hyperlipidemia we talked about, looking at your HDLs and LDLs. Your HDLs, we want to see them higher, and our LDLs, we want to see them lower, generally less than 100. Those that have developed what we call metabolic syndrome with high hyperlipidemia, and increase blood pressure, increase distribution of adipose around the abdominal area that we see frequently in women, can increase that risk. And then smoking, we talked about, and then hypertension. And those goals, really getting that blood pressure down and sustained less than 130/80 is what we're really targeting. So looking at the independent individual and some of those risk factors, that's where we really want to focus on primary prevention of having a stroke or an MI. So women do have an inherently increased risk of having heart disease. They tend to have a higher mortality, secondary to delayed presentation, vague symptoms, not your classic symptoms that we're used to seeing when we hear about someone who's having a heart attack. Their arteries tend to be smaller, so they can occlude much more quickly. Those risk factors, the general hypertension, obesity, but then adding on those hormonal changes associated with pregnancy and then menopause make that population a risk in itself for developing heart disease. So I put up some goals of care that we really want to focus on with our patient population. You can see there that for the general population with no diabetes or kidney disease, chronic kidney disease, we've got some goals in terms of blood pressure management. So those that are under the age of 60, our goal for blood pressure would be less than 140/90. For all ages, diabetes with cardiovascular disease, a goal less than 140/90. And then patients that do have those comorbid conditions with or without diabetes, such as chronic kidney disease, our goal is going to be less than 140/90. Now, the most recent literature is showing that we're now starting to target a goal of less than 130/80. You also have your fasting glucose levels there, and then suggested a lipid profile and BMI for your patients as well. And then how much physical exercise do we really need to engage in to help reduce that risk? And that's listed as well down there at the bottom of the screen. So I mentioned primary prevention, and this is really knowing that a person has a risk profile that we described earlier, like hypertension, diabetes, obesity, whatever it might be, but they have not developed symptoms of cardiovascular disease or coronary artery disease. And I'm going to use that interchangeably. They've not had acute MI, so we are going to try to mitigate that risk by managing some of those comorbid states, like they're making sure their diabetes well in control, blood pressure, get them assistance to help smoking if that's part of the problem. If we're talking about secondary prevention, it means that the person has had symptoms of coronary artery disease and they've had a prior event, such as an MI or a stroke. And now we're going to really focus on reducing the risk, modifying the life changes, their lifestyle changes to help prevent another acute event. And that's referred to as secondary prevention. And that's really what we want to focus on. But we also need to consider some of the social determinants of health. What are some of those things that could impact populations for developing cardiovascular disease? Is it economics? Is it the access to care? Is it lack of insurance? Whatever that might be. If we tell someone they have to exercise 150 minutes a week as a goal, but they live in a community that's high crime, or they have sidewalks that are not well fixed up, they've got holes in them, they're treacherous, you're probably not going to get someone out there that's going to go and walk the neighborhood to meet that goal. Just things to consider when we are trying to develop a plan for our patients. So I put a few quick quiz questions in this PowerPoint that you can pause and look at and see how well you do. Here's our first one. So a person has increased risk of coronary artery disease due to non-modifiable and modifiable risk factors. Which of the following includes modifiable risk factors? What do you think? Okay, so the answer to the first quiz is answer D. Diabetes, hyperlipidemia, hypertension, smoking, all the things we just spoke about are modifiable risk factors. I'm going to talk a little bit about the pathophysiology of coronary artery disease and the development of atherosclerosis and that plaque rupture and regression of the plaque that can have a systemic response. So there is a link between the vascular inflammation and atherosclerotic disease. It is a progressive disorder of the coronary arteries that results in this narrowing or complete occlusion. It affects the medium-sized arteries that perfuse the heart and other major organs. And there's three layers within that arterial wall. You have the tunica adventitia, the outer layer, the media, inner, and then endothelium is the inner part of the vessel. And that's where we see this plaque will deposit on the endothelium layer. This atherosclerosis is a chronic inflammatory disorder that essentially is characterized by accumulation of plaque, but it also triggers a vascular and inflammation or inflammatory response that causes injury to the wall. And deposits from cholesterol will infiltrate into that vessel wall on the endothelial surface. And here is where they develop this plaque that will align within the vessel itself. And normally the plaque may be quite stable, but as it matures, it can get bigger and disrupt that plaque and cause a systemic response where the body will send mediators like platelets to the area of the inflammation in the vessel where the rupture of the plaque has occurred. And this causes this cascade effect of all these platelets adhering to the wall. And this, as you can imagine, can occlude the entire vessel. And anything that prevents forward flow of blood with oxygen is going to result in ischemia. And that's what we see occurring in the coronary arteries when someone's having a heart attack. So one of the markers that we look at is the C-reactive protein, which is your CRP, which is a marker of inflammation that has been linked to an increased risk of cardiovascular disease independently. So acute coronary syndrome is really looking at three arms, which is the unstable angina, the STEMI, and the NSTEMI or non-STEMI MIs. But let's talk a little bit about angina, because what we do know in any one of those, there is narrowing of the lumen of the vessel. And how it gets categorized is some of the character of the type of angina, which is a symptom of coronary artery disease. So it's generally is chest pain, which is caused from myocardial ischemia. And it's not a disease, but rather a symptom itself. So it's telling us something. It can be caused from that occlusion from that plaque, clot, that prevents forward flow of blood. And it can also be caused by a vasospasm. And that spasm of the vessel can cause ischemia as blood flow is not able to move through that vessel like it did before. So in any one of those two scenarios, there's a lack of oxygen that causes the myocardial ischemia, and that's what the patient is feeling as chest discomfort or pressure or pain. It can occur anywhere in the chest, neck, arms, or back, and it's commonly described around pressure behind the sternum that may radiate to other areas like the left arm or to the back or the shoulder. And that's because the nerves that branch from the myocardium are coming from the same area that sends signals to the brain cells, and it interprets that deferred pain. So breaking down the different types of angina, you've got your stable angina, which is generally going to be patient that has some narrowing of the vessel. The pain will increase with exertion. Usually can get better with rest. And some of the patients may take nitroglycerin, and that is monitored by their primary provider. Usually when someone's having angina, there's usually about 70% of the coronary artery lumen is already occluded, but the cap, that plaque cap, fibrous cap, is stable. If the patient is having unstable angina, this generally means that there is an increased restriction of that vessel. The plaque has started to change. It will thin out, it will crack, and this is allowing those platelets and fibrin to aggregate to the actual injury itself in that vessel. The patient may start to have pain and pressure not associated with exercise, and often may not have relief with like nitroglycerin. So that is a much worse condition and officially fall under the ACS, which is acute coronary syndrome triad. Those patients need to be seen in the emergency department. They need to have a diagnostic 12-lead EKG, and then they need to have their biomarkers, troponin primarily, to look to see if this patient is truly having an injury within the myocardium. And they may be medically treated, or they may actually be admitted and have a PCI with a stent placed because of that narrowing has gotten worse. Your variant angina is also known as Prinzmetal angina, and that is from coronary spasms. So when the vessel spasms, it narrows and reduces blood flow to the heart. This commonly occurs in individuals at rest, and it's often a cyclic that occurs around the same time every day. There are things that can trigger it, like drug use, like cocaine or methamphetamine. It can also be triggered by smoking and alcohol use. The patient may have some ST changes on their EKG and chest pain. And generally, we will treat these with a dilator to help dilate that vessel. So calcium channel blocker and nitroglycerin may be the agents that we use. If we're talking about angina symptoms equivalents, this means that essentially that an individual has certain conditions like diabetes and hypertension that have the same risk of them having an acute MI. They just have not had an acute MI. They may have other symptoms, but we always want to investigate and to rule in or rule out. So like shortness of breath, they may have some diaphoresis, they may have exertional dyspnea. So we want to start looking at that population, and those patients may not have any chest pain at all, and develop an acute MI. So we see this in our elderly population, and we also see this in women, and we also see this sometimes in patients with chronic health conditions like chronic kidney disease and diabetes. So, and how are we going to manage these patients? I did add a visual for all of you to see how we break them down into acute coronary syndrome. And we looked at angina, but now you can see we've got not only unstable angina listed under the classifications under acute coronary syndrome, but your non-STEMI and your acute MI or STEMI MI. Those are going to be the three arms or triad that fall under ACS. So you can see that somebody that has unstable angina is not going to have that ST elevation that we talked about, and their troponins are going to be negative. Whereas someone who has an NSTEMI, they may not have ST elevation, but they will show positive biomarkers of elevated troponin. And then on your ST elevation or STEMI, that is your emergent acute MI. You'll see ST elevation on their EKG, and you'll have elevated biomarkers of troponin, and that is a medical emergency. And the reason being in your non-STEMI is you don't develop necrosis through the entire thickness of the myocardium. It's usually partial. So you will see those elevated troponins, but not necessarily that EKG change that we see with STEMI. And the EKG is really giving you a picture of what's happening within the myocardium. Here's another picture to kind of understand the different presentations. So once again, the stable angina, you can see you've got occlusion of narrowing of the vessel from that plaque, but you don't have any EKG changes, and you don't have any acute injury to the myocardium. In unstable angina, that plaque that was unstable now has the platelets and the fibrin that's occluding that vessel even more so, narrowing, and is starting to show EKG changes such as ischemia. And we see that with the flipped T waves and also ST depression here. But the biomarkers will be normal. In your NSTEMI, as you can see, there is an injury pattern that is occurring within the myocardium. But you don't necessarily see that ST elevation. You may see those ischemic changes like the flipped T waves and the ST depression, but the biomarkers will be elevated because there is injury. And then finally, your STEMI, you can see there is injury all the way through the layers of the myocardium, and that is depicted on your EKG as ST elevation, and you do have the positive troponins or positive biomarkers. So understanding each one of those is going to tell us how we're going to manage the patient. So medical management may be the focus, or we may need to do reperfusion interventions. So MONA is going to be the mnemonic that you may be familiar with and that you're going to use. MONA being morphine for pain. Usually we give about 2 to 4 milligrams IV. It is the analgesic of choice for pre-infarction angina, or to help relieve some of the pain that's not relieved by nitro. It does have a vasodilation property to it, and we do want to monitor for hypotension. O is going to be oxygen. Oxygen needed only if our oxygen saturations are below or low. Generally, we want them above 90, 92, 94%, around there. If the patient's having chest discomfort and shortness of breath, regardless of your saturation, you're going to put them on oxygen. Nitroglycerin is going to be the vasodilator that we want to give to help vasodilate the coronary arteries to help reduce that pain and injury pattern. And then our aspirin is going to be the other medication that we will need to give to every patient that we suspect is having acute coronary syndrome. That is best given if it's chewed. You don't want to give the enteric coated. You want to give usually 162 to 325 milligrams by mouth and have them chew it so it works faster. The other thing we may consider giving is a beta blocker, and the beta blocker is really meant to help decrease oxygen demand. We've already got an ischemic event occurring in the heart, so if the patient's got a tachyarrhythmia, they're hypertensive, then anticipate potentially that we're going to give a beta blocker to help reduce that oxygen demand. So our chest pain assessment is going to be an important tool to identify if this patient has chest pain associated with a cardiac event, and then actually if it's a cardiac event, is it ischemic or a non-ischemic event? So you've got some questions down there that can help you with that assessment, identifying the onset, how long it's been going, generally what have you done to treat it, what happened beforehand, do you have any symptoms associated with it, what's the quality of the pain, does it radiate anywhere on the scale, how severe is it, and any other associated symptoms. Are they nauseous? Are they sweaty? Do they have shortness of breath? In non-cardiac chest pain, we can see this in a whole lot of different diagnoses. It can be from a panic attack to somebody using drugs to a GI problem, a pneumothorax, a PE, even a musculoskeletal problem or anything that has to do with movement, pleuritic type pain. And then you've got your cardiac, ischemic versus non-ischemic, and these can be such as a pericarditis that we talked about. That's inflammation of the sac that surrounds the myocardium. They have a tamponade or they've got fluid around the heart. An aortic aneurysm. Those are just some other examples of cardiac problem that's non-ischemic that can have chest pain. Okay, so once again, we're looking at a little bit more of the definition of a myocardial infarction. And it is an irreversible myocardial necrosis or cell death that results from an abrupt decrease in the amount of blood flow that's carrying oxygen to a specific part of the heart itself. We already talked about what an NSTEMI would look like and a STEMI. And we know that artery occlusion can come from from several different things, such as a plaque rupture, a thrombosis, a new thrombosis that forms on the plaque, or a spasm itself. But there's ischemia, and the tissue is at risk. And within the first 2 hours, if we don't restore perfusion to that area of the myocardium, then that part of the myocardium will not be salvageable. It essentially will be necrotic. And then that's a whole different problem in itself. So the outer part of the area where the infarction is occurring is called the zone of ischemia. And that's also synonymous to the penumbra that we talked about in stroke, the area that's salvageable, that if you can restore perfusion has the best outcomes of being reperfused without any complications. You will see this ischemia on your EKG with what I refer to as flipped T waves or T waves going in the opposite direction, or some ST depression. Those are signs of ischemia. And that is because of the repolarization of the cells in that area. It will manifest itself as the T wave on the EKG. So that's what we're seeing. That picture on the EKG. So flip T waves we're looking for. In our injury pattern, there's an infarcted zone that potentially can be viable if we can restore perfusion. We call that the zone of injury here. And this is where we look at the ST segment, and that's going to show us, do we have elevation in the ST segment? Usually this is going to be at least in 2 consecutive leads, and we'll talk about more of that when we look at the different parts of the myocardium, and at least 2 boxes above the isoelectric line, or what we we're at the J point. This is the population when we have that injury pattern. We want to either give them a reperfusion therapy, such as a thrombolytic, or take them to the cath lab to remove that clot. In the infarction, this is what we call the zone of infarction. This is the area that is necrosis. So this myocardium, this part of the myocardium is necrotic, and this will show itself on an EKG as a new pathological Q wave, a Q wave that was not present before. It's generally about 1/3 the length of the R wave, and this may be permanent, or it actually might resolve over years, and that's because this area has been replaced with scar tissue. So that Q wave MI is really telling that we've got all 3 layers that were impacted by ischemia, and that's referred to as a transmural MI. If a patient has a pathological Q wave but no ST elevation, that is an old infarct, and they are not eligible for thrombolytics. This is another picture to kind of show you what we were talking about. It points out at the top on the left there, that zone of ischemia. You can see the outer part of where the infarction occurred. That is like the penumbra, and you can see that flipped T wave. It should be upright, and it is not. It is flipped downward. So that's a sign of ischemia. Then you've got that zone of injury, and that is your ST elevation. MI, and then your pathological Q wave or zone of infarction, the unsalvageable area has that Q wave that's formed, and that new Q wave is going to be indicative of infarction. Okay, so this table you really want to be familiar with. You want to be able to identify the leads on your 12-lead EKG that will look at a certain surface of the myocardium, and what vessel is involved in that type of MI. So if somebody has ST elevation in 2, 3, and AVF, it is the right coronary artery that has been affected, and it is supplying blood to the inferior part of the myocardium. Then you've got your lateral, your anterior, and oftentimes anterior lateral will go together. That shows you what those leads involved would be, and then your septal, and then your posterior. And as you can see in the picture with it color coded, these are not next to each other on the 12-lead EKG. So they're color coded to help you identify the group of EKG leads that involve that surface of the myocardium when somebody is having an ischemic event. Now, just a few things about these different types of acute MIs. Your anterior wall, for example, it's a large area. It's right up front, so it's involving a lot of the left ventricle, which is your pump. And if it involves the left ventricle, then you may have failure of that pump, and that is a patient that can go into acute heart failure or cardiogenic shock. We're going to see arrhythmias here. We're going to see patients that become hypotensive. They may have the ventricular arrhythmias like VTach, VFib. In your inferior wall MIs, this vessel is the right coronary artery, and that provides blood flow to the AV node, the SA node, so and also is very preload dependent. So if this part of the myocardium is impacted, you're going to see patients at risk for hypotension when we do give a vasodilator like nitroglycerin. You also are more likely to see the bradycardias here and your heart blocks in an inferior wall MI. In a patient that has a lateral wall MI, these patients oftentimes have the anterior wall involved as well. And once again, these are your patients that have heart failure, cardiogenic shock, and a lot of those VTAC or ventricular ectopy or arrhythmias coming out from the ventricles. So kind of think about those patterns that will help you identify which vessel is involved and what surface of the myocardium has been impacted. Okay, there are several complications that can occur when patients have an acute MI. Sinus bradycardia might be one of them, especially if the inferior wall or inferior wall MI has occurred. And that's because the pacemaker, SA node, and AV node has been affected. So you would treat that the same as your bradycardia algorithm by giving atropine per guidelines, and then possibly pacemaker, transcutaneous pacemaker or pacing, I should say. Sinus tachycardia can occur as well with patients with the anterior wall MI or just accelerated rhythms as well, leading to further ischemia. So this is where your beta blockers can be helpful in the oxygen consumption. You can have atrial dysrhythmias. Patients can develop atrial fibrillation, for example, and lose that atrial kick that can lower their blood pressure and then lead them down to heart failure and cardiogenic shock. They can have a lot of ventricular dysrhythmias, depending on how much of the myocardium has been affected. You can have an aneurysm that occurs, or a weakening of the wall of the actual myocardium itself. A rupture of the septum can occur. Papillary muscle rupture also. This is a complication that occurs generally about 2 to 7 days after the initial MI. They may have a new mitral valve regurgitation that is noted on exam. And that's because some of the structures, like the papillary muscles, were involved in that MI, and they are not going to be supportive for those valves anymore, so they can rupture itself because they're damaged. You can have a cardiac wall rupture, pericarditis, or the inflammation of the sac around the myocardium itself, or the patient can go into heart failure and can also have another MI. So lots of complications. That's why these patients need to be monitored very carefully for these complications and treated and recognized as soon as possible, so that we may end up having to take them back to the cath lab and to help restore perfusion. Okay, so if the patient does have elevated biomarkers, we're looking at the troponin. Troponin I, generally, if it's greater than 0.49, your high sensitivity troponin, if it's greater than 14, and then looking at our 12 lead as your diagnostics. Those are the two things that we are going to evaluate if the patients have an acute injury pattern. We talked about MONA already, the medication and medical management that we will implement. We will start those patients on anticoagulation and antiplatelet therapy. And they may actually be on antiplatelet therapy for life, depending on what intervention was done. If the patient does go in for to the cath lab, sometimes we will place a stent. So we perform angioplasty and essentially putting a balloon in that vessel, blowing up the balloon and pushing that plaque up against the wall. And then sometimes we'll place a stent to keep that patent. Those patients will need to be on antiplatelet therapy, dual antiplatelet therapy, so that they don't develop another clot. So we're looking at aspirin, something like Plavix, and what we call that is DAPT. DAPT stands for dual antiplatelet therapy. Anticoagulation will also be needed, and so patients will be put on something like heparin, Lovenox, and some of those agents. And then we talked about the beta blocker. Some of those patients may be placed on a beta blocker and also an ACE inhibitor. And what that does is help reduce ventricular remodeling that can occur after the patient has an acute MI. So we want to make sure that we prevent that remodeling, because there's a lot of complications that can occur structurally within the myocardium that we want to help prevent. And it can lead to significant incidences of heart failure. We may also put them on an antidysrhythmic, such as amiodarone, and just depending on what some of the potential complications or actual complications they've had. So we want to really focus on, in terms of nursing management, is really balancing the myocardial oxygen supply and demand. So these patients need to be on some sense of rest initially with not too much exertion. We need to give that myocardium some rest. We need to monitor them for arrhythmias. It's very common to have reperfusion arrhythmias after we've restored perfusion. We want to assess for any type of new chest pain and get a rapid 12-lead EKG to see if the patient has another area of infarction or reinfarction. We're going to monitor their cardiac output and help support that by administering medications that might be ordered, like dobutamine or dopamine or milrinone, to help keep good cardiac output, that positive inotropic of contractility, keeping that heart going. So we improve cardiac output, and then also help dilate some of the vessels as well in the pulmonary system, so they don't develop complications in the lungs as well. And then monitor for some of those complications. If they have received a thrombolytic, we want to monitor those patients for bleeding post-administration, because they can have a high risk of bleeding when we give a systemic clot buster. And then we're going to start assessing for the patient for potential plan for rehab. Address things like depression, which can actually be pretty prevalent in this population after having an event such as an acute MI. Lots of nursing management involved, medications, education, diet, reconciliation of maybe meds that they were on at home, and then getting the patient ready for discharge. Okay, So we can't talk about acute MIs and not mention sudden cardiac death, which is why there's such a big campaign out there for learning CPR, how to use an AED, early defibrillation. Most likely the mechanism of sudden cardiac death is from VTAC, which moves into VFib, which are not compatible with life. And though some of those patients may never even make it to the hospital, out of hospital cardiac arrest still does not have a great survival rate. Even if they're admitted to discharge, they may have poor outcomes. And this is really what should I say, a community education awareness out there in the community on what to do if they suspect that somebody is having an acute MI, activating EMS and getting that patient to the closest cardiac center so there's no delays in reperfusion. So early recognition. There are other things that can cause sudden cardiac death, like cardiomyopathies, heart failure, those types of things as well. And then also things that can cause sudden cardiac death in young populations, like hereditary problems, Wolff Parkinson White, prolonged QT syndrome, and Brugada syndrome. And so there's a lot of other things that can cause sudden cardiac death and not just an acute MI or ischemic event. Okay, so I added in some of these slides from the treatment module, and it's appropriate here, so I kind of put them together. So this is fibrinolytic therapy, also known as thrombolytic therapy. This is looking at patients that are not at a center that has a PCI availability, so they're not a cardiac center. So we may end up giving them a fibrinolytic and then transferring them to a center that can do PCI. We always want to consider that there are risks associated with getting a thrombolytic. As you can imagine, it is systemic, and so patients that do receive a thrombolytic do have a risk for bleeding. So you want a good history. You want to know if they've had any head injuries, if they've had any GI bleeds, if they've had any bleeding disorders. Those patients may not be candidates at all for thrombolytics. There's also a risk of angioedema that can occur after getting a thrombolytic. And then we also want to make sure that we've got good blood pressure control, just like with the stroke population, before we administer a thrombolytic as well. So generally getting the blood pressure less than 180/105. Now, there are certain patients that will have a diagnostic EKG with elevated ST elevation, just like we talked about, in certain leads, and some that will have what we call a new left bundle branch block. If the patient has a new left bundle branch block, we cannot fully rule them out for acute MI. We will draw the biomarkers, but because that bundle branch block will obscure what we would normally see ST elevation on the EKG. So it basically masks it or hides it. So you may hear a physician or provider say, let me have the old EKG and compare it to the new EKG. If there was a left bundle branch on the old EKG and it looks the same as today, then we can use that as a diagnostic tool to rule them out for ST elevation. If it is a new left bundle branch, we have to assume and get biomarkers and make sure that the patient is not does not have an acute MI. Okay, we talked a little bit about exclusion criteria, patients we should not give it to. The fibrinolytic or thrombolytic agent that you will need to just be generally familiar with. You don't need to know the dosing, how to calculate any of that, but TNK, tenactoplase, is the one that we are currently using. Tenactoplase can be used for any clot anywhere, so it's not just used for MIs, it's used for stroke, it's used for PEs, it can be used for clots in other areas. So all of the exclusion criteria would be the same for each one of the situations, bleeding being the greatest risk. So for TNK is generally just a bolus that is going to be given IV push. And then the idea is hopefully that we can have some clot dissolve to help restore perfusion. And then a patient may go for PCI to remove the remaining of the clot. Very similar of what we do in stroke. You don't need to know this description on the slide below. This is just looking at the restoration of flow, but this is how it's actually graded. Okay, so how do we know that the patient has reperfused? So a few things that you're going to be looking for. Is there restoration of pain? Did the pain go away after we gave the thrombolytic, after we gave the TNK? So the pain, and then also, did the ST segment now resolve? They back at the isoelectric line. They don't have ST elevation any longer. Their biomarkers are going to take time, so that's not a reliable way of gauging whether the patient has had complete reperfusion, that will resolve over the next couple weeks. One thing that you want to be mindful of is reperfusion dysrhythmias, which can happen oftentimes when we restore perfusion. All that blockage can cause a lot of bad stuff that's built up essentially. And when we open it up, it's flooded with a whole nother property that causes irritability to the myocardium. So reperfusion dysrhythmias are common, and the most common is idioventricular rhythm. So that is from that washout from all that damaged myocardial cells that were occluded behind that clot, and now it's gone through the circulation because we opened it up, right? The vessel with either the fibrinolytic or balloon angioplasty and a stent. So idioventricular rhythm is going to be your most common dysrhythmia seen in post-reperfusion. Okay, so once the patient is up in the ICU, we're going to monitor them for all the bleeding that may have occurred. You want to look at the site where they punctured, either the groin or in the radial region. You want to make sure that they're not developing a hematoma. You're going to monitor their vital signs, make sure you keep your blood pressure down below parameters. So oftentimes that might be via a drip. It's not a good idea to have fluctuations in blood pressure. So a lot of times the patients will be on a drip if they've got hypertension. And then you're going to monitor for other signs of bleeding, not just from the puncture site, but do they have blood when they urinate? Are they having a change in mental status? Are they having a GI problem or a GI bleeding? Those are going to be some of the main things that you're going to be looking at. You're going to be doing education with the family. Some bleeding is normal after they've gotten a thrombolytic, such as bleeding when they brush their teeth, maybe a little oozing out an IV start site. But other than that, those are okay. It's the big bleeds that we really worry about. So we're going to monitor their labs, and sometimes these patients have to get blood products. So we talked about thrombolytics as one reperfusion intervention, and generally we want to give that within 30 minutes of the patient's arrival. If the patient is going to the cath lab, our goal to get them to the cath lab if they're at a cardiac center is less than 90 minutes. And if they have to be transferred, the goal is 120 minutes. But essentially, this is the angioplasty that's done, and to help push that plaque up against the wall. And then, like I said, oftentimes going in and actually stenting that. Uh, So these are just the different types of percutaneous interventions that can be done in the cath lab. And you don't really need to know these. They're just there for your information. Just to know that the gold standard is PCI or angioplasty and possible stent placement for patients that have atherosclerotic disease in their coronary arteries. We've already talked about the complications with those, but this is just for your information. Like I had mentioned earlier, if the patient does have a stent in place, then we will have them on dual antiplatelet or DAP therapy and anticoagulation to help prevent the stent from developing a clot itself. So commonly this will be your aspirin and Plavix, and then a anticoagulation like heparin or Lovenox. So monitoring them for bleeding and also education on taking their medications. After discharge, some of these patients will be on antiplatelets for life. Here I've just given you some of the most common oral antiplatelet agents that your patients might be discharged. So some of them that you're probably quite familiar with. These are your IV infusion antiplatelet agents that patients may be on as well. Oftentimes we used to put them on a patient that was going to the cath lab at another facility. We would give the thrombolytic, we would give the aspirin, and then we would start them on an integralin drip. And then send them over for PCI at a cardiac center. So I put two videos on here that you can take off the slides and view. This shows you the procedure itself. It's quite fascinating and has really come a long way in reducing mortality for patients with acute coronary syndrome. But you can just see here, kind of like we talked about with the brain, that restoration of blood flow to that area. You can see in the first picture, there is a large clot there, so the contrast can't get beyond that clot. And then once they take the clot out, they will give them more contrast, and then you can see there's now restoration of that vessel is patent, and that area of the myocardium is now perfused. Okay, so patient has had the percutaneous intervention done. It's being admitted up to the unit. Things that we're going to assess and help manage. Monitoring the patient for that new onset of chest pain or new angina. So we want to quickly get them a repeat 12 lead if it's a new chest pain. And get that patient on nitro if we can, if this is an ischemic injury that's occurring, and then potentially can go back to the cath lab. We also want to help protect the kidneys. They've gotten a double hit with contrast oftentimes, so AKI is very common. So this might be giving hydration, sodium bicarb to help improve perfusion to the kidneys. And then pharmacy is usually pretty good at looking at medications that are nephrotoxic as well, and using alternatives if there is a hit to the kidneys there. We talked about the vascular side again. What closure device they use is going to depend on the institution. Could be an angioseal, for example. And then making sure that you not only assess the site, but you are assessing the retroperitoneal area around the flank area, that they aren't developing a hematoma. And then what is their peripheral vascular assessment when they arrive from the cath lab. We're going to assess those vital signs. We're going to look at that at least every 15 minutes for that first hour. And then we're going to do that peripheral assessment as well. Not only are we going to check for pulses, but we want to look at cap refill. We want to temperature of the extremity itself. As you can imagine, being in an artery, if they develop a thrombus there, you can lose perfusion to that extremity, and patients have actually lost legs and limbs over some of the complications that can occur. So we want to be really diligent on our assessment. Okay, so there are certain situations where PCI is not the best treatment for this patient. Someone that has the LAD that's involved, that large vessel, the LAD will feed a lot of the other vessels. So that is a very high risk type of MI. And so those patients may end up having to go in for what we call a CABG or coronary artery bypass surgery. Also, a patient that might have multiple vessels involved, like triple vessel disease, then these patients are better surgical candidates than they would be for percutaneous intervention, which is in the cath lab. And as you can see here, there is essentially a removal of the vessel, oftentimes in the lower extremities, that saphenous vessel, that will now become a conduit, or I should say, they will anastomose the vessels to pass the area of necrosis or injury through open cardiac surgery to help keep perfusion to that area of the myocardium. So you essentially have two types of surgical intervention. One for the lower extremity, the saphenous vein graft, and then you have the open heart for the bypass that's done in the operating room. Sometimes open heart surgery will also involve valvular repairs. Like I had talked about, a complication that can occur with patients that have had acute MI. You will have structural problems that can occur because of the areas of necrosis on the myocardium. That can affect a lot of things, the structures of the different structures of the heart, including the valves. And so patients can develop a new valve problem, usually regurgitation, and may need to go in and have a procedure done to open up a incompetent valve, maybe put in a prosthetic valve, and then there's a much newer procedure that I left a video for you to look at if you want to, called the TAVR, and that's much less invasive procedure now. Okay, so post-operative management for a patient that's had cardiac surgery, things that we want to look at is fluid deficit problems, monitoring their I's and O's. A lot of this due to some of the third spacing that can occur. And this can actually lead to edema, fluid overload, weight gain, and due to the capillary permeability with fluid being drawn into interstitial spaces. You also can have myocardial depression with decreased cardiac output. So we want to make sure that we are supporting the contractility of the myocardium. May need to give them a positive inotrope during the recovery period. We want to monitor for coagulopathies, bleedings, monitoring our INR. We want to look at our electrolytes and make sure that we are not having any type of myocardial irritability from electrolyte imbalances, especially magnesium, potassium, calcium, that we haven't developed a new pulmonary edema as a secondary complication from fluid overload, for example, and fluids shifting into the lungs. Hemolysis from all the red blood cells that get damaged during the pump circuit that's often used in bypass surgery. They put them on temporarily, but they can develop hemolysis. And then making sure that our blood sugars are within goal, usually 140 to 180. We're also monitoring, we talked about the electrolytes, monitoring those, but we're also looking for any change in their neurostatus or any decline. Population is at risk for microemboli, so embolic stroke. So we want to make sure that we recognize a change and get a rapid CT if needed of the brain, and then making sure that we've got good blood pressure control as well and good blood pressure support. Sometimes we need to give some blood to help support the pipes and keep them full without overload, but we have to really be careful on these patients and not being too liberal with fluids and blood and throwing them into heart failure or cardiogenic shock. These patients will often arrive with a lot of invasive lines. So remember when we are supporting cardiovascular support, cardiac output, we approach it with the formula we learned: cardiac output equals heart rate times stroke volume. So we want to look at our heart rate. Is it too low or is it too high? And modify that if we need to, whether they're been placed on pacemaker, a temporary pacemaker, or a temporary pacemaker wires that they may come back with. Do they have a tachyarrhythmia that we need to have them on an anti-dysrhythmic? And then for our stroke volume, we're going to approach preload first, and we want to look at their CVP, what is their wedge pressure. So we're looking at preload, and if it's low, address that by giving fluids or blood. If it's high, then we may need to give them a something to help diurese off, or a vasodilator. After load, so looking at their systemic vascular resistance, do we need a vasodilator versus something to help squeeze the pipes to improve their afterload? And then we want to look at our contractility. How is the pump working? Do they need support with a positive inotrope, dopamine, dobutamine? Temperature-wise, we want to keep them normothermic, and then control any type of bleeding and monitor that. If the patient does have complications, sometimes these patients have to go back to the operating room. These are just some different medications. You won't need to know this for the exam. Just be mindful. Some of your patients may have these for bleeding, to treat the post-operative bleeding. We are using TXA a lot more in the inpatient setting, so I wouldn't be surprised if you see that as well. Oftentimes, your patients may come back with chest tubes, even bilateral chest tubes. And those will be in temporary. So we want to make sure that we're have them set up properly. We don't have it clamped. Another complication that can occur is cardiac tamponade, often referred to as Beck's triad. So this is a medical emergency and a complication that can occur in the postoperative period. Essentially, there is fluid that is building up in that sac, pericardial sac, where there really shouldn't be fluids. And it can be blood, it can be serous sanguineous fluid, but it builds up and it becomes a tourniquet around the myocardium, and therefore the heart can't pump effectively. And so we need to release that band, and that can be done with a pericardiocentesis, and we can withdraw some of that fluid out of the sac. The signs that we may see is JVD. You may see a narrowing pulse pressure as the cardiac output goes down, so a drop in their blood pressure, and then muffled heart sound. So that's the three triad of the Beck's triad or cardiac tamponade. These patients are going to be intubated when they arrive in the post-op period, and while we're stable them hemodynamically, make sure they're not bleeding. We also want to do very diligent on pulmonary care, and we'll be monitoring at the earliest time that we can actually sprint them from the ventilator. Early extubation has the least amount of complications. If we can get them up, walking, and off the vent, those risks for VAP, infection, aspiration, all those things go up the longer the patient does have a tube in or it's intubated. We always talked about the neurological complications like an embolic stroke that can occur from microemboli, and like I said, infection and acute kidney injuries. And these are the things that we're going to do ongoing and monitoring. Okay, I put just some information in here of things and topics that you can discuss with your patient following any cardiac intervention. So education is going to be very important. Should start at its earliest point, I should say, and follow throughout discharge, being reinforced. There are going to be some pretty significant lifestyle changes, so it's going to take time for a patient to go through cardiac rehab and adapt to the new lifestyle. So give them time and start education early. Okay, our next quiz question. Which device can be used to initiate a heartbeat when the heart's intrinsic electrical system cannot generate a rate adequate to support cardiac output? What do you think? If you chose answer C, you are correct. Pacemakers are electronic devices that can be used to initiate a heartbeat when the heart's intrinsic electrical system cannot, and we kind of learned about that. And there are all different types of pacemakers. There's transcutaneous pacemakers, which are temporary. And then there are your transvenous pacemakers that patients could have temporary wires placed post-cardiac surgery so they can pace the electrical conduction system. And so pacemakers can also be permanent, and they are placed surgically. They can also function as a defibrillator and a pacemaker, which you've learned about in your EKG lectures by Dr. Richards. Well, we wrap up this part one of cardiovascular conditions and treatment. I wanted to touch on some other procedures that can be done. These are patients that have stenotic vessels other than in the coronaries. The carotids would be another area that can cause problems and result in stroke due to stenosis. So currently the treatment for patients that have stenosis, anything greater than 70% stenotic, will need to have some type of intervention. If they are less than 70% but are symptomatic, then we will also do interventions. One of them is a carotid endarterectomy, and this is a vascular procedure that's done in the operating room. And essentially, there is a cut open to the carotids, and they will remove the athero plaque that is in that vessel, and then sometimes place a stent at the same time. These patients go under general anesthesia. There needs to be good neurological assessment for bleeding, and also the cranial nerve assessments because of the nerves that the area that they're working around surgically can be affected. They could be cut or have some type of damage to them, and the patient may develop problems with like swallowing, may have some weakness on a side of their face from the facial nerve. So there are some complications to that. The patients that have stents, a lot of times we will put them in the interventional radiology lab where they don't need to go under general anesthesia. They have moderate sedation. They'll put a stent up into the carotids. They may do angioplasty like we do in the coronaries. They just go up into the neck, push that plaque up against the wall of the vessel, and then put in a stent. Those patients will also need to be on DAPT or the dual antiplatelets, like Plavix and aspirin. And then another vascular procedure is the abdominal aortic aneurysm repair. So this is an invasive surgical repair for someone that has a ruptured aneurysm or dissection. And so these patients will also go to the cardiovascular ICUs for monitoring that graft, monitoring for bleeding and perfusion. With a lot of these procedures, you want to always do a really good peripheral vascular assessment to make sure that there is no compromise. All right, another quiz question. Which device can issue a shock to the heart? What do you think? All right, if you chose answer A, that is correct. A ICD is an electronic device that is a permanent device that can actually defibrillate, and it can also pace. And we just talked about that in a previous slide, but essentially you will see a protrusion in the tissue. You always want to avoid that if you are placing defibrillator pads on the patient's chest. And then those patients, if they've had an ICD put in many years ago, they're generally not MRI compatible. More in the last several years, more of those devices are MRI compatible. So you always want to do your MRI checklist, make sure the patient's safe to have an MRI if that's what is needed for the patient. Okay, lastly, I have left a few slides for your review. These are the common cardiovascular medications that your patients may be on. You've learned about quite a few of these in your other classes, your ACLS, your EKG class, when you looked at your titration guidelines. So you can refer back to those as well. Knowing which medications are cardioselective, which receptor they're working, the stimulus is responding to. So your alpha, your beta, one heart, beta two lungs. Your common antidysrhythmic agents are listed here with their dosages and actions, special considerations. You won't need to know all these medications, be familiar with the most common that we see with this population, such as dopamine, dobutamine, cardizem, and amiodarone. which are your medications that are positive inotropes, which ones are sympathomimetic agents. You want to be generally familiar with those.